Welcome to this advanced simulation session on neonatal complex case management, evidence-based diagnosis, and treatment. This presentation will walk you through some of the most challenging neonatal cases, helping you build clinical decision-making skills that go beyond the basics. Throughout this journey, we'll encounter preterm and term infants with critical conditions, explore multi-system involvements, and practice how to integrate evidence from current research into practical treatment plans. Whether you're a neonatology resident, NICU nurse, or pediatric specialist, this session is designed to sharpen your diagnostic thinking and make you more confident in complex case scenarios. So, grab a notepad or open your clinical mind. We're about to enter the neonatal intensive care battlefield. By the end of this simulation, you'll be empowered to not only recognize clinical red flags early, but also to take charge using up-to-date, evidence-driven interventions. Let's get started. In this module, we have 4 core learning objectives to guide us. First, you will improve your differential diagnosis skills. That means when a newborn presents with overlapping symptoms, you'll be equipped to think broadly and critically. Second, we'll practice how to approach complex presentations systematically. Instead of rushing into decisions, we'll show you how to layer your investigation thoughtfully. Third, we'll reinforce the use of evidence-based diagnostics. You'll learn to interpret lab values, imaging, and clinical signs with more precision. Finally, we'll implement tailored treatment plans that manage more than one condition at a time, because in the NICU, it's never just one thing. You'll also be guided on how to use the latest literature, applying recent research in a real-world clinical setting. Keep these objectives in mind as we explore each case. Think of this as your clinical GPS. It's what will help you stay on track when the road gets bumpy. This isn't just a slideshow. It's your survival toolkit for when the NICU turns critical. Let's get into it. Let's talk about how we approach a complex neonatal case. It begins with a meticulous physical examination, not just checking vitals, but also assessing skin, tone, reflexes, and perfusion. Then, we move to targeted laboratory investigations. These aren't random tests. They're selected based on the baby's symptoms and risk factors. Imaging like cranial ultrasounds or chest x-rays may come next to clarify what labs alone can't reveal. And finally, clinical synthesis. This is the detective work, taking all the clues you've gathered and assembling them into a logical, prioritized management plan. This framework helps reduce diagnostic error and prevents tunnel vision. Remember, a newborn isn't just a small patient. They're an evolving clinical puzzle, and this framework helps you put the pieces together, one step at a time. All right, your first real patient. Baby, a 32-week preterm baby, grunting, flaring, retracting, and oxygen saturation is stuck at 85%. What's your move? This isn't just one disease. It could be cross-mark respiratory distress syndrome, cross-mark sepsis or pneumonia, cross-mark pneumothorax, cross-mark or a missed congenital heart defect. Here's what separates pros from panickers: structured decision-making. Heavy checkmark, order a chest x-ray. Heavy checkmark, get that blood gas. Heavy checkmark, check a full blood count and culture. You're racing the clock, but with a clear mind. Interactive check-in. What's your top diagnosis right now? Keep that in mind as we reveal the results. And the results are in. Chest x-ray? A ground glass haze with air bronchograms, classic for RDS. Test tube blood gas? Respiratory acidosis. pH 7.25, PCO2 elevated, and low PO2. Microscope CBC? WBC okay, but slight drop in platelets, Fire blood culture? Boom, group B strep positive. Now it's confirmed. RDS plus neonatal sepsis. Double trouble. Here's the magic. These clues don't compete, they complement. You don't treat RDS or sepsis, you treat both. Light bulb the real-world insight? Babies often don't read textbooks. Be ready for mixed pictures and always consider infection even if it looks like a lung-only case. Up next, we'll hit the treatment strategy that can turn this baby's future around. Let's go. Time to act. Here's your battle plan to save this baby. White heavy checkmark step 1. Respiratory support. Depending on severity, Start with CPAP, but be ready to escalate to mechanical ventilation if needed. The goal? Oxygenate without overinflating those delicate lungs. White heavy checkmark step 2, surfactant therapy. This baby has RDS. Follow the ENSURE protocol, intubation, surfactant, then extubation to CPAP. It's fast. It's effective. White heavy checkmark step 3, antibiotics. With GBS sepsis confirmed, hit hard, ampicillin and gentamicin. Don't wait. White heavy checkmark step 4, supportive care. That means thermoregulation, glucose control for fluids, and nutrition. Never underestimate the basics. They keep the baby stable while the meds do their job. Pushpin quick tip: document everything and monitor closely. In neonatology, even the smallest changes matter. Let's break down surfactant options next, because how you deliver it could mean the difference between ventilator days and home. You've got 2 surfactant weapons, let's compare. Gear, ENSURE technique. Intubation, deliver surfactant, then extubate fast to CPAP. Why it works? You minimize ventilation time, less barotrauma, lower BPD rates, faster discharge. Stethoscope Lisa/MIST method. This is the ninja technique. Less invasive surfactant administration. No intubation. Just a thin catheter while the baby breathes spontaneously. Advantages? Even fewer complications. More natural breathing. Less sedation. Less trauma. Magnifying glass tilted left. What does the evidence say? The Cochrane Review backs early surfactant use. Mortality goes down. The AAP supports early rescue surfactant. Lisa is the new gold standard. When you can do it. Fire clinician's edge. Master both. Choose based on equipment, skill, and baby stability. Let the evidence guide you, but let your hands decide. Now that we've stabilized, here come the curveballs, the complications. Counterclockwise arrows button PDA. Echo shows a left to right shunt. Start with fluid restriction. If significant, go pharmacological, indomethacin or ibuprofen. Save surgery for the last resort. Brain IVH, the dreaded bleed. Grade 2 on cranial ultrasound. Management? Stability is everything. Prevent pressure swings. Monitor for hydrocephalus. Drop of blood NEC warning signs. Distended abdomen. Feeds not tolerated. Call it early. Go NPO. Start broad-spectrum antibiotics. Insert NG tube for decompression. Light bulb, here's the pearl. Neonatal complications are dominoes. Spot the first wobble before they all fall. So, how did we do? White heavy checkmark respiratory distress? Resolved. White heavy checkmark sepsis? Cleared in 14 days. This baby made it. But the journey isn't over. Memo discharge planning must be strategic. Start RSV prophylaxis before the next viral season. Book neurodevelopmental follow-up. Look out for CP, tone issues, delays. Don't forget hearing screening. Sepsis and ototoxic meds can impact it. Repeat button long-term. Pulmonary function testing, developmental surveillance, and family counseling. This isn't just about saving lives. It's about protecting futures. Brace yourself. This one's intense. SOS button term infant. APGAR. 1 at birth, 3 at 5 minutes, 5 at 10 minutes. Cord pH? A terrifying 6.85. At 4 hours of life, seizures begin. The neuro exam? Hypotonic. Floppy. No suck. But it's not just the brain. Stethoscope kidneys, not functioning. Heart struggling to perfuse. DNA liver enzymes up. Brain, deeply insulted. We're facing full-blown Hypoxic-Ischemic Encephalopathy with multi-organ damage. Here's your mission: cool the brain, stabilize the body, and buy time. In the next slide, we'll launch the most powerful therapy we have for HI. Stay with me. Before we move to Case 2's life-saving hypothermia protocol, don't forget. Backhand index pointing right. Subscribe for more high-stakes medical simulations. Backhand index pointing right. Hit like if this gave you a clinical adrenaline rush. Backhand index pointing right and share with a fellow NICU warrior. It might change how they practice tomorrow. Next up, how cooling a baby's brain by just 3 degrees can change everything. You have one window. 6 hours. That's all. To give this baby a chance, we initiate therapeutic hypothermia, the only proven treatment for moderate to severe HI. Here's how it works. Snowflake Phase 1 Initiation. Cool the baby to 33.5 degrees Celsius within 6 hours of birth. Not 7. Not 8. Time is brain. Ice cube Phase 2. Maintenance. Hold temperature plus or minus 0.5 degrees Celsius steady for the next 72 hours. Fire Phase 3. Rewarming. Slow and steady. 0.5 degrees Celsius per hour. Never rush it. You're reactivating a fragile brain. But it doesn't stop with temperature. You monitor every organ, every shift. Brain watch for seizures. Drop of blood, watch the blood pressure. Red heart, watch the heart rhythm. Exclamation mark interactive challenge. If this protocol is delayed, how does that affect outcomes? Drop your thoughts in the comments. When a baby is this sick, you don't treat a system. You treat every system. Brain neurology. Continuous EEG. Seizures are often subtle, even invisible. Phenobarbital first line. Levetiracetam if needed. Growing heart cardiology. Volume expansion. Echo daily. Use inotropes to maintain perfusion, but don't push too hard. Droplet renal. Fluid restriction is key. Diuretics may help, but be cautious. Overhydration worsens brain swelling. DNA hepatic. Check clotting. Support with vitamin K. FFP if needed. Respiratory. Keep oxygen in the sweet spot. Avoid both hypoxia and hyperoxia. Collision pro tip. The brain doesn't heal in isolation. It needs the whole body to be stable. Is all this effort worth it? Let's talk numbers. Ice cube therapeutic hypothermia reduces mortality in HI babies by 25 to 30%. Brain, it slashes the risk of severe neurological disability. Books backed by massive RCTs and meta-analyses. And guess what? The earlier you start, the more dramatic the benefits. Even better, brain MRI plus AEG during and after cooling can predict outcomes with 90% plus accuracy. But don't forget, cooling isn't a magic wand. It's most effective when started on time, in qualified centers, with skilled monitoring. This is where neonatal medicine moves from guesswork to precision care. Seizures in HI babies can be silent killers, subtle lip smacks, eye deviation, apnea spells. You need AEG. Here's the first-line arsenal. Pill phenobarbital at 20 mg per kilogram, our go-to. If seizures persist, high-voltage levetiracetam, phenytoin, or midazolam step in. Still seizing? Consider a therapeutic coma with lidocaine or continuous infusions. Lightbulb quick tip. Always correct metabolic imbalances before escalating drugs. Electrolytes, glucose, calcium, they all play a role. Brain, the goal isn't just seizure control. It's brain protection. That's what we're fighting for. Can we predict the future? In neonatology, sometimes, yes. Here's how we forecast outcomes in HI. Chart decreasing abnormal AEG at 6 hours? 72% predictive of poor neurodevelopment. Brain MRI at 5 to 14 days, 88% predictive accuracy. White heavy checkmark combine both. Boom. 94% accuracy. These tools help us guide families. Planned interventions. Prepare for what's next. But remember, predictions aren't destinies. Early intervention, rehab, nutrition, all can rewrite the story. So ask yourself, are you making space for hope, even when the odds are hard? If you believe every baby deserves a fighting chance, smash that like button. Speech balloon got a case like this? Drop your story below. Your voice could help someone else learn. Bell, and don't forget to subscribe. We have more real-life NICU dramas coming your way, including the story of a 980G baby who fought off NEC and sepsis. Trust me, it's inspiring. You've cooled the brain, controlled the seizures, supported every organ. Now what? The NICU may discharge this baby, but the real journey begins at home. Brain neurological assessment is your compass. Watch for tone abnormalities, asymmetric reflexes, missed milestones. Test tube cognitive evaluation needs to be early and continuous. Simple screenings aren't enough. Use structured developmental tests and refer to early intervention when needed. Eye, ear, vision, and hearing? Absolutely critical. HI survivors often have hidden sensory losses that don't appear until months later. Calendar golden rule: follow up until school age.
Why?
Because attention issues, speech delays, or learning disabilities often surface years later. This is where we shift from saving lives to shaping quality of life. Welcome to the next battlefield, a 28-week preemie, 980 grams. Suddenly, the belly's distended, the baby's cold, bradycardic, and feeds are being thrown up. Your mind should scream, NEC. This is a gut emergency. Every hour counts. But here's the twist: NEC rarely travels alone. Look deeper.
Get the labs.
Get the X-ray. Prepare for a two-front war: sepsis and gut necrosis. Let's break down this baby's numbers next, and they're not pretty. Let's zoom into the diagnostics. Abdominal X-ray. Pneumatosis intestinalis. Portal venous gas. That's Bell stage IIB, NEC. Drop of blood CBC. WBC down to 2,800. Platelets? Dangerously low at 48,000. Fire CRP? Through the roof, 125 milligrams per liter. The body is on fire. Petri dish blood culture. Positive for Klebsiella pneumoniae. That's a gram-negative punch. DNA coags. PT18s, PTT48s. Fibrinogen 120. DIC is in motion. This isn't just NEC. This is septic NEC in full attack mode. Every system is screaming. You've got to move fast and smart. Let's build the treatment plan. Time to go full code mode. Keycap 1 bowel rest. NPO immediately. Insert an NG tube and start parenteral nutrition. Keycap 2 antibiotics. Triple coverage: ampicillin, gentamicin, metronidazole. Don't go soft. Keycap 3 surgical readiness. If perforation or clinical deterioration hits, call the OR. Keycap 4 cardiovascular support. Fluids, inotropes, stabilize pressure, perfusion, and oxygen delivery. Direct hit the mission. Halt progression. Avoid perforation. Prevent shock. Light bulb pro tip: NEC needs team huddles. Every few hours. Because change is constant. What if we could prevent NEC in the first place? Good news, we can reduce risk. Baby bottle breast milk is your first shield. It reduces NEC risk by more than 50%. Test tube probiotics? Controversial, but meta-analyses support them in select preterm populations. Chart decreasing slow feeding advancement is no longer favored. What matters more? Consistent and individualized feeding protocols. Woman health worker antibiotic stewardship is crucial. Overuse kills gut flora and invites NEC. Pushpin, and here's a twist: early trophic feeds with mother's milk might prime the gut in a good way. Speech balloon interactive pause. Does your NICU use donor milk for NEC prevention? Let us know in the comments. If you're learning something new with every slide, like, comment, and share this video with your NICU crew. Woman health worker, man health worker, whether you're a nurse, a resident, or a med student, this is how real-world neonatal care looks. Television, and hey, hit subscribe, we're just getting started. The next case? We meet a baby with NEC who ends up in surgery. You've done everything. But the belly's growing, the vitals are crashing, and the X-ray now shows free air. This is surgical NEC, and the OR is calling. You've got two main choices. Wrench primary peritoneal drainage, PPD, a bedside option. Tiny incision, relieves pressure, especially for fragile, extremely low birth weight infants. White heavy checkmark, less invasive. White heavy checkmark buys time. But here's the kicker: 30 to 50% will still need full surgery later. Hammer and wrench, exploratory laparotomy, the gold standard when bowel is necrotic or perforated. You go in, remove dead bowel. Sometimes reanastomose. Sometimes create an ostomy. Balance scale, the NET trial showed outcomes are similar between both methods. So what matters? Stethoscope the baby's stability, your team's experience,
and time.
Loudspeaker clinician's corner. Don't delay surgical consults. Even if you're not sure yet, get the surgeons in early. Surviving NEC is just the beginning. Puzzle piece, let's talk post-op complications. Keycap 1 short bowel syndrome. After extensive resection, the baby can't absorb enough nutrients. White heavy checkmark solution. Long-term parenteral nutrition, slow reintroduction of enteral feeds, and support for bowel adaptation. Some may need bowel lengthening surgery. Keycap 2 intestinal strictures, scar tissue that narrows the bowel. Police car light symptoms, vomiting, distension, late onset obstruction. Camera with flash diagnosis, contrast studies. Kitchen knife fix, surgical resection or strictureplasty. Keycap 3 nutritional challenges, chronic malabsorption. Baby requires elemental formulas, scheduled feeds, and micronutrient support, iron, zinc, vitamin D, selenium. Light bulb remember, nutrition is medicine. Every kcal counts in recovery. New patient alert, full-term infant. Looks cyanotic, gasping for breath. Scaphoid abdomen. Chest looks too full? This is congenital diaphragmatic hernia, and it's not just anatomical, it's hemodynamic chaos. Lungs underdeveloped. Broken heart shoved to the side. Blue circles, severe hypoxemia. Despite intubation, O2 sat is dropping. Echo confirms pulmonary hypertension, PPHN, right to left ductal shunting, RV strain. The pressure is building, literally. Round pushpin the battle plan? First stabilize, then repair. Let's map out how to get this baby through the storm. Your first move? Protect the lungs. Always. Gentle ventilation only. Avoid overdistension. High-frequency oscillatory ventilation, HFOV, may be needed. Test tube avoid hypercarbia and hypoxia. These fuel pulmonary hypertension. Lotion bottle place an orogastric tube to decompress the stomach. That's extra pressure off the lungs. Syringe hemodynamic stabilization. Preload support, inotropes close monitoring. Brain and yes, monitor cerebral perfusion. These babies are fragile upstairs too. Pulmonary hypertension? Fire up inhaled nitric oxide, ENO.
Start at 20 ppm.
Adjust based on SpO2 and echo. Consider milrinone or sildenafil if things don't improve. And the elephant in the room? ECMO. We'll talk about it next. Brain clinical reflection. In CDH, surgery can wait, but oxygenation cannot. CDH is one of the most dramatic conditions in neonatology. And when conventional therapy fails, ECMO steps in. Stethoscope in the next section will reveal when to escalate, how ECMO changes the odds, and what the long-term survival looks like for these babies. Directed if you've made it this far, you're not just learning, you're becoming a neonatal warrior. Loudspeaker, smash that like button. Open mailbox with raised flag, subscribe for part 6, ECMO, surgery, and the final case, a mystery metabolic disorder that reveals itself in one shocking lab test. Now we zero in on the real villain behind CDH, pulmonary hypertension, PPHN. This isn't just a side effect. It's what makes or breaks outcomes. Direct hit your mission, reduce pulmonary vascular resistance, support systemic perfusion, and avoid anything that worsens the shunting. Optimize ventilation, preductal SpO2 between 90 to 95%. Keep CO2 normal. Overventilation or hypoventilation. Both dangerous. Test tube start ENO at 20 ppm, then adjust. Use dopamine or epinephrine to keep systemic BP, pulmonary pressure. Pill if ENO fails, bring out the backups. Right arrow, sildenafil. Right arrow, milrinone. Right arrow, prostaglandins, in select duct-dependent cases. Police car light still crashing? ECMO is next. Pushpin neonatal pearl. Always define your ECMO threshold before you reach it. That decision should never be made in panic. Once stabilized, the next move is surgery, but timing is everything. Hourglass not done, delayed repair after stabilization gives better outcomes. No rush to cut. First, make sure baby is ready. Hammer and wrench approaches. Traditional open repair, tried and true. Minimally invasive, shorter recovery, but not ideal for unstable patients. Thread technique. Close the defect primarily. If it's huge, use a patch. Bar chart outcomes. In experienced centers, survival is 70 to 90%. But remember, success isn't just surgery. It's the entire pre-op resuscitation that sets the stage. Camera with flash want to go viral with a story? Feature a CDH baby who is crashing then walks out months later. That's the kind of content that educates and inspires. When conventional therapy isn't enough, we call in the big guns. ECMO, extracorporeal membrane oxygenation. Pushpin indications? Oxygenation index, OI, greater than 40. Refractory hypoxemia. Hemodynamic collapse. Chart-increasing ECMO can improve survival by 20 to 30% in eligible CDH babies. But there's a catch. ! Higher complication rates than in other ECMO patients. ! Risk of hemorrhage, infection, clotting. ! Neurodevelopmental outcomes vary. Hospital and, here's the kicker, center volume matters. High-volume ECMO centers have better outcomes. Brain bottom line? ECMO is a life-saving bridge, not a solution. Use it wisely, and only in places that know how to wield it. You've made it to the final slide, and now you know why neonatology is one of the most demanding and rewarding fields in medicine. Let's recap what you've learned. High-voltage early recognition of subtle signs saves lives. Bar chart targeted diagnostics beat broad, wasteful testing. Books evidence-based treatment outperforms guesswork. Handshake teamwork is your superpower. Nurses, RTs, neonatologists, surgeons, all working together. Repeat button and finally, reassess constantly because what's stable now might crash an hour later. Every case, every baby, every second, it all matters. Speech balloon interactive reflection. What was the most eye-opening case for you? Drop it in the comments and share what you'd do differently next time. If you learned even one thing today that could save a baby, like, share, and subscribe. Baby, the next life saved might be because you watched this video. Lightbulb, keep thinking, keep questioning, keep caring. And remember, in neonatology, small hands hold the biggest stories.